Good morning, everybody, and welcome to our Stanford Cancer Institute's Frontier in Oncology. And it's my pleasure today to introduce Dr. Hashem El-Serag, who is a physician scientist and best known for his research in liver cancer, HCC, and the hepatitis C virus. He received his MD degree from El Arab Medical University in Benghazi, Libya. And I wish I had time to really go through his journey to the United States. But he moved here and he started his residency in New Jersey and then moved to do an internal medicine residency at Yale and received his gastroenterology fellowship at the University of New Mexico in Albuquerque before he received his Master of Public Health from the University of New Mexico. Dr. El-Serag's work on the incidence of hepatocellular carcinoma, which was published in the New England Journal in 1999, was the beginning of his remarkable career. He's published nearly 600 scholarly papers. His work of greater than 100 publications on HCC represents much of the modern literature on the epidemiology of HCC in the United States. He's world-renowned in research, leadership, and all aspects of academic medicine. Dr. El-Serag has received numerous awards from Glaxo Wellcome, Digestive Health Foundation Award for Healthcare Advancement in 1997, the American Gastroenterology Association's Young Clinical Investigator Award in 2003, the American Gastroenterology Association's Master Award in Clinical Research in 2005, the world's most influential scientific minds in the area of clinical medicine in 2014, the Bin Kara Award in 2016, and the local Baylor Award of the Michael DeBakey Excellence in Research Award also in 2016. Dr. El-Serag was selected as a member of the American Society for Clinical Investigation and as a member of the American Association of Physicians. Sorry about that. He was chief of the Gastroenterology and Hepatology Division from 2007 to 2016 at Baylor College of Medicine. He also served with me as leader of the Cancer Prevention and Population Sciences program at the Dan L. Duncan Cancer Center. And then he was also chief of Clinical Epidemiology and Outcomes Division at the Michael E. DeBakey VA Medical Center in Houston. In 2017, he was selected to serve as the Margaret M. and Albert Alkek Chairman of the Department of Medicine at Baylor College of Medicine, where he was actually my chair as I was the division head of epidemiology. He's been funded by multiple research grants from the NIH, the Cancer Prevention Research Institute of Texas, the VA, and many professional societies. In 2014, he became the director of the Texas Medical Digestive Disease Center, funded by a P30 NIH grant, and one of the only 6 successful centers in the United States. He was the associate editor of Gastroenterology, the leading specialty journal, and editor-in-chief of the Clinical Gastroenterology and Hepatology from 2012 to 2017. And then he became chair of medicine in 2017 and has taken the department to great heights with the Blue Ridge rankings, taking it to number 25. In 2018, he was elected president of the American Gastroenterology Society. And I just have to say that Hashem has a great sense of humor. And when he gives his annual Grand Rounds talk to the fellows on how to present a lecture, he says, you always start with the joke. So it's my pleasure to introduce Dr. El-Serag, who's been a friend and colleague for many years.
Thank you very much, Melissa. Thank you, everyone, for waking up early in California. I mean, 8 o'clock. You should guys be surfing or doing whatever Californians do. Melissa, it's great to see you. We miss you a lot at Baylor, and thank you for inviting me here. A couple of corrections to your introduction. First, I wish I taped it to make my mother-in-law listen to it. I think she would have enjoyed it. Second, I got the American Gastroenterological Association Young Investigator Award not in 2003. It was last year. Just kidding. Not that. And last thing is, and the crowd probably have noticed this already, given my name and my accent, I actually am from Houston right now, as you can tell. So I'm gonna now go, jokes by the way, do not project fantastically in Zoom, but the good news is I'm immune from seeing the crowd reaction. So I don't know if you're laughing or you're not, I'm just pretend you are, and I'll just plow on. I will talk about hepatocellular carcinoma turning into a more serious issue. This is a picture of the liver that has cirrhosis in it. And in it, there are multiple nodules of liver cancer or hepatocellular carcinoma. And
Dr. El-Serag, we need to share your screen, please.
Oh, that too. All right. Does that work?
Yes, thank you.
Okay. So it's a rare tumor. This is a slide from my fellowship days. And this is what we used to present in grand rounds. That's 20 years ago. Rare tumor affecting older men, typically infected with hepatitis B as a result of some earlier exposure, happens in patients with cirrhosis, and that was that. Things have changed, and they've changed as follows. All right. So this is a color-coded map that shows the age-adjusted mortality rates worldwide. And the very dark areas indicate the hotspots or areas that are with the highest mortality rates for HCC. And it tends to cluster in sub-Saharan Africa and Southeastern Asia. And it's related to hepatitis B in these countries. If this map was drawn 20 years ago, the United States was actually in the less than 3, the areas where it was not supposed to be a problem, rarely reported cancer, but things have changed in multiple areas of the world. And what this slide shows that areas that are high in the red in the previous slide have started declining. So for example, Korea, parts of China, and Italy have declined, while you have the green line, which is the US. Notice how low it was in the mid 80s, and both in whites and blacks going up. So 24 years ago, I was at the University of New Mexico as a fellow, and I discovered 3 things. I had a more enlightened resident who discovered something called the WWW, and he swore in a bunch of Bibles that he can access this thing and he can download the vital statistics of the US broken down by etiology. And while he was doing that, New Mexico, which happens to be a SEER registry site, came up with this new invention called CD-ROM. And they were giving free CD-ROMs on a weekend in Albuquerque if you attend a seminar for half a day. So I showed up there and I got my CD-ROM. The problem is I didn't have a computer. So I waited for the month after that to buy a computer, and I worked the CD-ROM. The resident downloaded the vital statistics. And in the meantime, my master's in public health, my main specialty was programming SAS, because I wanted to access the national VA databases programming SAS. So a combination of these 3 events happened in 1998. And in one fateful weekend, we downloaded 3 figures. One shows hospitalization, one shows mortality, and one shows incidence for liver cancer. And all 3 were going up. And at the time, there was no PubMed. So we hit the library looking for index medicus to see, has anyone ever published this? And the last publication on liver cancer was 20 years earlier, showing that it's a rare cancer in the US with no signs of increasing. So with the naivete of a postdoctoral fellow who was graduating into his first post as a faculty, we sent those 3 things to the New England Journal of Medicine as my first paper as a faculty, containing 3 graphs showing hospitalizations, mortality, and incidence. And it was a leading publication in the New England Journal of Medicine, and the rest was history, as they say. A few years later, because it was easy, we thought, why don't we update the rates? So we did, and it was published in the Annals of Internal Medicine, a lesser journal with a longer title. A few years later, because it was really easy, we updated it a third time. We were just running out of titles, so we called it The Unbelievable Rise in the Incidence of HCC. Really, no, we did not have that third installment. By that time, I think it became a common fact. Our latest installment, however, was in 2017, and it has more nuanced interpretation of the rates. So this shows the age-adjusted incidence rates for hepatocellular carcinoma divided by the major racial and ethnic groups. The very top line shows Asian Americans. Remember, this is the group that I referred to in the first slide, the color-coded coming from Southeast Asia. Basically, these are recent immigrants from countries where hepatitis B is endemic, and they've always been the group at the highest risk of developing HCC at this country. It's not the most frequent, but the highest risk. But for the first time in 2012, this group has been superseded, surpassed by Hispanics or Latinos in this country in the blue line. So now Latinos constitute the group with the highest or the fastest rising incidence rates of HCC in the US. The other three lines shows Native Americans, African Americans, and Caucasians, all of whom have been rising steadily. So looking at the states, California and Texas belong to this red belt that has been developing since the 1990s. And the three maps here are 2003, 7, and 12. You see more darkening or reddening of the map, indicating increased incidence and mortality related to HCC, with a cluster in southern states and western states. And the country that currently leads this rise in hepatocellular carcinoma, the state was a country in the past, I gave it away, is Texas. So what's about Texas? This is more a Texas-centric analysis. The top three lines are Texas. The bottom three lines are the nation. All show age-adjusted incidence rates for HCC. The very top line is Texas Latinos. And as you can see, Texas Latinos have 3 to 4 times the rates of the national HCC rates. And it tend to cluster in border counties, border meaning bordering Mexico. So at a time when incidence for cancer of all causes in the US is declining, there are few cancers, specifically 4, that maintain an opposite trend. Liver cancer leads the way. So it is the fastest rising cause of cancer-related deaths in the US. These rates are increasing disproportionately in Latinos, and particularly Latinos who are either of Mexican origin or close to Mexico. So what's the cause of that? Traditionally, and this slide was drawn in 1999, if you look at multiple series from small places in the US, they indicate that half of the cases of liver cancer or hepatocellular carcinoma have an underlying hepatitis C, that's HCV. A small sliver would have hepatitis B, a very small sliver would have both of them, and then you have this big wasteland of 33% that wasn't really an important thing because we knew the rest of the pie then, that we called idiopathic, cryptogenic, probably they drank, they just lie about it, all that stuff. And I will take you through the story to show how this portion of the pie, the 33%, is gaining increased attention nowadays. So what happened to hepatitis C? So there used to be a time, and thankfully that time is gone, when I would spend the entire hour saying that we have 3 to 4 million people infected with hepatitis C, only a small proportion would develop liver cancer. Who are those unfortunate people? And I would go describing the different risk factors, modifiable, non-modifiable, maybe viral genotypes, all of that stuff. We spent years and tens of papers describing the epidemiology of hepatocellular carcinoma arising in hepatitis C. Unfortunately for us, fortunately for the patients, this epidemiology is virtually obsolete because the only risk factor that remains nowadays for hepatocellular carcinoma in hepatitis C is, have those people received antiviral treatment, and did they achieve SVR, which stands for sustained virological response, which means cure in other words. So there are those medications that you, even if you don't know the area, you must have turned on the TV and seen a commercial for Harvoni or Clusa or any of these medications. And the studies that show the efficacy of these medications are extremely boring. It's a bunch of bars that basically compete who's closer to 100%. These are medications that are taken orally that virtually work in everyone. If not the first combination, the second one, that basically removed hepatitis C from our clinics. So those in contemporary liver clinics rarely, if ever, have active hepatitis C. So what happened to hepatocellular carcinoma once the cure has been achieved? We conducted one of the first studies to indicate the outcome vis-a-vis HCC and hepatitis C. This is one of the few sort of detailed data slides that I'm going to show. We examined almost 24,000 patients with hepatitis C that have been identified through the national VA system. Remember my SAS programming background. Luckily, I don't program anymore. I just know enough to annoy the programmers by pretending that I know how to program. So 23,000 or 24,000, 22,500 fulfilled the eligibility criteria. And what are those eligibility criteria? They completed DAA. DAA meaning directly antiretroviral. These are the super duper new medications and didn't have prior HCC. As you may expect, the vast majority of the 22,500 have responded with cure or SVR, 19,500, and a small proportion, but because we started with a very large number, that small proportion translates almost 3,000 people who didn't get cured by the first course of treatment. Then we followed them through the computerized file to see who developed HCC or not. 183 developed in the first group, 88 in the second group. And if you plot the cumulative incidence as shown in this graph, there are two observations. The y-axis is the incidence of HCC. The x-axis is months after the end of treatment for hepatitis C. The first striking observation, the SVR or the cure rate, there's a dramatic, sustained, started early reduction in the incidence of hepatocellular carcinoma among those with SVR. Going back to my 2 slides ago, basically it's a major predictive factor of HCC, and in this case, a negative predictive factor. Those who did not respond clearly have a higher rate. The second thing is that blue line. Those who got cured, while low, did not return back to 0. So there is still a residual risk of developing liver cancer, even among those who got treated successfully with SVR. Then you ask yourself, who are those unfortunate people who got treated, got cured, still developed HCC? Well, our a priori hypothesis, which I'm going to link it to my first slide, is the only relevant risk probably remaining is the presence of cirrhosis, which is the end-stage fibrotic scarred liver at the time of treatment. And we were proven correctly. So stratifying the results by the presence or absence of cirrhosis at the time of the treatment shows that among those with cirrhosis, that's the very top right corner, the annual incidence of HCC among those cured who had cirrhosis at the time of treatment is 1.82%. That's really, really high if you think about it. Every year, almost 2% develop after cure in the presence of cirrhosis. As I mentioned, the rest of the epi doesn't really matter except for ethnicity. So age and diabetes and alcohol and all the things that used to matter in the past doesn't. Those red dots just line up. It's either cirrhosis or not. Those without cirrhosis are almost out of the woods. The annual incidence is between 0.1 to 0.2% per year, quite low to justify any sort of regular follow-up. So that's the story for hepatitis C. And where we're taking the story is, well, I believe for clinical purposes, we're unlikely to be seeing those active hepatitis C in our clinic. We're still likely to see those who are not treated and haven't been detected, still presenting with cancer. So what we're doing for them is trying to predict the residual risk of cancer. And we have now a calculator that we developed called HCC Risk Estimation Algorithm. You can see the website, and I invite you to check it out. As you can tell by the HES, it's a complete coincidence that my initials are Hashem El-Serag. So it's just happened to resemble what's in this calculator. It incorporates alpha fetoprotein, rate of change, which is a biomarker, rate of change within the past 12 months, concurrent ALT, which is a liver enzyme test, and platelets, basically tests that people obtain normally and routinely. And we found that this gives you a better prediction than not having anything in your hands of who is going to develop HCC or not. I'm going to skip this, but it basically shows that based on the scores of the calculator, there's a real differentiation. You're going to end up with people who are in the red or the purple, who have really high risk, or people in the yellow who have really low risk. So at least you can distinguish people on those both ends. This is how our calculator ends. And this is how I'm going to end the hepatitis C portion. So all of the stuff that I mentioned doesn't really mean anything as far as the epi. Well, this slide shows the incidence of HCC stratified by the underlying etiology among those newly diagnosed HCC cases. And two observations are important to make. Hep C is still king. So Hep C positive HCC is 60% of all HCCs, even 2014. But it has been declining, and has been declining progressively, but sharply so, since the advent of these newly efficacious treatments. Then you can see in the triangle, which I will dedicate a good portion of the last part of my talk, presumed non-alcoholic fatty liver disease is making an increase there. So I don't want to pretend that hepatitis C is over. And the reason I don't want to pretend this, and this is sort of not epidemiology, but public health, is if you look at the so-called cascade of care, and you start by what we think we know, that there are 2.5 million infected hepatitis C people in the country. As of 2018, we think that 900,000 have been identified. This number is now higher, it's 1 point something. But still, half, or at least a third, hasn't been diagnosed yet. So you can see how there is a major drop in whatever intervention you're going to have, caused by the fact that most people, or a good portion of those people, haven't been diagnosed yet. Once they're aware, there's a smaller drop in the treated, but as you can see, those two bars, the treated and cured, are becoming equivalent because you have a tremendous treatment that works in everyone. So what I'm trying to say here is the rest now is public health related to screening, diagnosis, linkage to care. And once they're linked to care, I think it's over in a good way. They will be treated and cured. There's another annoying thing. Annoying would be a gentle way of putting it. If you live in the Midwestern states, it's more than annoying. It's a killer epidemic, which is the opioid injection epidemic. And there seems to be a resurgence of acute cases of hepatitis C concomitant with the opioid use. There's still low number of cases. I don't think they'll come anywhere close to the main HCV epidemic that was caused in the 60s and 70s, but it is something to watch, and it's something that may disrupt what I assume will be a precipitous loss in hepatitis C and a gradual decline till very low over the next 10 to 20 years of liver cancer related to hepatitis C. So now for real, I'm done with hepatitis C. So if you're wondering how do you screen for hepatitis C, it used to be complicated. Like you have to remember a bunch of risk factors, which no one can remember and no one asks and therefore no one answers. Then they simplified it and they said baby boomers. Unless you know what a baby boomer is, you probably didn't do it because it meant you have to remember those born between 1945 through 1965. I was born in 1966, FYI, so I missed that screening. Now they really made it easy where they say any adult between 18 and 79, screen them one time for hepatitis C. So if you want your bottom line, how do you continue the prevention of HCV-related HCC? Screen for HCV, one-time routine, make it opt-out screening, all adults, one-time testing for those who are younger, but if they're increased risk. If you find it, it's a no-brainer. Treatment and cure will result in 2020 in sustained virological response virtually in everyone. What remains if you treat them? Diagnose cirrhosis. Do they have it or not? If they don't, it's over. They're good. If they do, then you want to continue screening surveillance until we know more about this group. And that's the HCC surveillance step. So hepatitis B, and it's hypocritical of me, I'm dedicating 3 slides or 4 to it. It is the major etiological risk factor underlying probably half to 60% of all cases of HCC worldwide. It has a cheap, effective, widely available vaccine that in a perfect world, everyone would get it. However, this world is, as you know, not perfect. So HBV vaccination uptake remains low in many countries. And the blue is the encouraging part. Why it's encouraging? Because the United States is greater than 90%, but equally important, Southeast Asia, which used to be the source of immigrants with hepatitis B, is really, really high now on the HBV vaccination, high enough that having recent immigrants who are below the age of 30 or 40, their rate of hepatitis B is just as low as those who are born in the United States. So I'm fast forwarding to say this is the reason for my hypocritical, disproportionately low presentation on Hep B, because from a nationwide public health, it is not quote unquote a big deal, although those who have it, obviously, it's a big deal for them. So what about hepatitis B? If you don't get vaccinated and you have hepatitis B, who develop liver cancer? Well, I used to give even longer lectures dedicated to who are the unfortunate few who develop hepatitis B-related HCC. You should be familiar with my ploy now, because I'm going to show that most of the epi is really gone. I mean, we said tens of papers on hepatitis C. Well, in Southeast Asia, they've had thousands of papers on hepatitis B, completely untreated. They've given us models and predictions and viral dynamics among people who do not receive treatment. Well, the paradigm has shifted where antiviral treatment, although it does not cure hepatitis B yet, it results in HBV DNA suppression. The indications to give that antiviral treatment has ever been creeping up, that a lot more people are now eligible to receive treatment. And those who receive the treatment, most of these factors that were highlighted on the slide are no longer relevant. The most important clinical risk factor for getting hepatitis HCC in HBV, are they on treatment? And is the treatment working or not? So this is an older study that demonstrates the point, just like our study from the VA demonstrated the point of hepatitis C treatment. Lamivudine is an older, now really not very effective treatment, but even then, treating cirrhotics with hepatitis B in this large Taiwanese randomized controlled study resulted in a reduction in the orange. Those who are on lamivudine had half the risk of HCC or decompensation in this case. So what are we doing in this area? Again, we're doing whatever is relevant right now. If you have people who are on treatment and they're showing up, as they do show up, what do you tell them about the risk of hepatocellular carcinoma? So with the collaboration with Taiwanese collaborators, we've constructed this model and externally validated it. It's called CAMD, C-A-M-D, and it stands for cirrhosis, age, gender, and diabetes. Cirrhosis is a recurring theme here, and look how many points it gives people if they have cirrhosis, even though on treatment, the risk of HCC goes high. So this example shows how you can, by different scores, identify different risk strata for HCC among those who are treated for hepatitis B. Again, I encourage you to look it up. It could be useful for you clinically. And so prevention of HBV, HCC, vaccination, vaccination, vaccination. I think what I tell clinicians all the time is one of those few things that are actually useful is screening for hepatitis B and or vaccinating if you don't want to screen or if you think the status is negative. Remember that immunity wanes, so adults in high-risk groups can and may need a repeat vaccination. Screening for hepatitis B, treating if the screening is positive, and diagnosing cirrhosis because it really is the residual risk factor for HCC, even among those on treatment, and then conducting surveillance for those who have cirrhosis and in select groups that I'm not gonna get into without cirrhosis. So now obesity. So there's a global pandemic related to obesity called Globesity. The United States leads the way. So what is the link between obesity and hepatocellular carcinoma? If you're an alarmist, if you're an advocate, if you're someone who wants to raise the issue, you would flash a study like this. This is a New England Journal of Medicine study, one of those annoying cohorts that they keep publishing on in the East Coast. I don't know, Nurses Health Study or someone. But basically showing that among obese men, it couldn't have been the Nurses Health Study, sorry, so maybe Physicians Health Study. Obese men with a BMI 35 or greater, followed for several years, have an increased risk of all cancers. You probably have seen various permutations of this slide. But the permutation I'm showing here is while all cancers are increased in risk among obese men, the cancer with the highest increase is liver cancer. So if you're an alarmist, you would say, look at that, 4.52 relative risk increase among obese people compared to non-obese. But the overall picture is a lot more nuanced. Most, but not all studies have shown an increase that is significant between the risk of HCC and obesity. And among those that showed, the risk is actually small. So this is a meta-analysis of several observational studies that show in the overweight category where the diamond is, it overlaps the one. So basically overweight was not a risk factor for HCC. Obesity is barely a risk factor. It's less than 2, and it has a lot of variations in it. So maybe a weak risk factor. But there's an issue here about obesity and cancer. Examining that in a crude distal way, I believe is not useful. So what do I mean by distal? Obesity measured by BMI has 2 problems. First, BMI doesn't really capture or may not capture whatever is bad about obesity in causing cancer. Second, because BMI overweight or obesity, which is greater than 25, is becoming now what, 2/3, 70% of the population, it is actually very difficult to show differences in risk if you don't have differences in exposure. So at some point in time, obesity may become like oxygen, 100%. Everyone knows that. And therefore, something says failed to detect my microphone. Can you still hear me?
Yes, we can hear you. We can't see you.
Oh, that's not the worst thing you can say. Now
There
you
we
can
go.
hear me.
Thank you.
You're welcome. So obesity, A, measured by crude things, B, very common. HCC, for those, and I know a lot of people in the audience study signaling and transduction and pre-cancer and early cancer. So for them, HCC, when it develops, it's the train wreck. By that time, it's too late. It's very difficult to know what caused what. So the move in the field and in our research is to take it a step closer. No longer obesity measured by BMI, but measure things that are proximal, like abdominal obesity, like visceral component of the abdominal obesity, like humoral mechanisms that may be indicative of obesity, medications related to that, or intermediate lesions like non-alcoholic fatty liver disease or genetic factors. And in HCC, we're looking at the precursor lesion, like cirrhosis, for example. So I'll show a couple of examples that just tells you where we are in this. So remember what I mentioned about obesity measured by BMI. The risk was not consistently high. The average risk, the conglomerate risk was barely 1.7 to 2. If you move to the few studies that examined waist-hip ratio as opposed to BMI as the main exposure, you find two things. First, the studies are consistently showing an association between high waist-hip ratio and HCC. So for example, in this study, the highest tertile of waist-hip ratio conferred threefold higher HCC risk. So more consistency in the risk and higher risk, indicating that maybe you're hitting something that is more relevant than BMI. What I'm not showing here for HIPAA reasons, the face, but it was my face, and that's how sort of Melissa left me when I gained weight. Fortunately, with COVID, I stepped up the exercise and diet routine, and I look like this right now. You don't have to laugh. I can't see anything. So I want to highlight, what do I mean by the role of abdominal obesity if you take it a step further, more proximally, and look at visceral versus subcutaneous. This is a hypothetical cross-section among two people, or between two people. They have exactly the same BMI, 31. They actually have exactly the same abdominal diameter. The person on the left has a smaller gray area, which is the visceral fat, compared to the person on the right, which is having a greater one, 200 centimeters square. Without going into the details of cholesterol, LDL, HDL, or triglycerides, the person on the left has normal numbers. They're metabolically normal. The person on the right is metabolically very abnormal. So going back to my point, if you use a crude measurement like a BMI or even a waist circumference, what hides in variations is important. And that's why you end up with studies that gives you the average of the risk as opposed to what the risk is. So we're moving now, measuring whatever that gray area secretes. I don't have a slide on it because the results are all over the place. But the new wave of studies now measures adipokines, cytokines, both protective and increasing risk, to see if these predict HCC better than just obesity. More importantly, and I want to tie it into my original epi slide, why Latinos? Why Mexican Latinos have a higher risk of HCC? Well, if you believe this plot about abdominal obesity, there are population-based studies that measured using CT scan and MRIs and DEXA the different compartments of fat in the body. And the striking difference is between African Americans and Latinos, where Latinos, pound for pound, pack more fat in their belly, particularly in their visceral fat compartment, compared to African Americans. And Latinos, risk factor for risk factors, always, in all studies, have a significantly higher risk of developing cirrhosis and HCC compared to African Americans. So it's just another sort of track of explaining the risk that seems to fit and explain the overarching epidemiological trend. So continuing the theme of, if BMI doesn't explain it, can we look for intermediate things? We've conducted the first cohort study examining the role of diabetes type 2 as a possible risk factor for HCC. We looked at 173,000 patients with diabetes, 3 times the number without diabetes, followed them over time up to 14 years, HCC rate on the y-axis, a doubling of the rate of HCC among diabetics compared to non-diabetics. Since that publication, 25 other cohort studies have been published, and 18 of those show a similar association, and the relative risk is remarkably consistent around 2. So type 2 diabetes is associated with a double risk of HCC. Don't panic too much here, because if you look at the y-axis, the actual absolute rate is small, but it is doubled. So if diabetes plays a factor, what about the treatment of diabetes? Many studies have been done, and if there's some magic there, it may relate to metformin. Metformin have been shown in experimental studies as well as clinical studies to be associated with a reduced risk of cancer in general. Esophagus and colon are included, but HCC is one of them. And at least in the epidemiological studies, there's a 50% reduction in the risk of HCC among diabetics treated with metformin compared to insulin. And the other treatment is statin. I don't need to tell this group, statin have been examined virtually with every cancer with inconsistent and variable sort of estimates and reports. We've conducted the first of such reports relating to HCC back in the early 2000s. And we found that in a large cohort, we've done a nested case control study, statins, but not other cholesterol reducing medications, were associated with a reduced of HCC risk. And the odds ratios are shown here as a 0.63. So the big intermediate lesion that everyone is talking about right now that you need to be aware of is non-alcoholic fatty liver disease, which may progress to something called non-alcoholic steatohepatitis, NASH. This slide is color-coded map, again, that shows 2 estimates. Each area has 2 boxes. The top number is the population-based prevalence of NAFLD in the underlying population, and the bottom in any of these boxes is the prevalence in type 2 diabetes. And the numbers are obviously staggering. The prevalence of NAFLD in North America is 25%. And if you look at Latinos in Texas, it's 33%. 1 in 3 adult Latinos in Texas has NAFLD. In the US, the prevalence of type 2 of NAFLD in type 2 diabetes is more than half. In Europe, it's 68%. In the Middle East, it's 67%. Those numbers are not unbelievable, because if you look at any liver clinic right now, it's basically 99% NAFLD and its derivatives. So how bad is NAFLD? It's a new entity, relatively speaking. The epi is soft, but these are some of the estimates put in a cartoon. NAFLD progressing to NASH, probably 10 to 25% over a decade. NASH to cirrhosis, probably 10% over 10 to 15 years. Once cirrhosis develop, then that is the precursor lesion for HCC. But there are 2 red arrows here that make NAFLD even more scary or more annoying or more problematic. That NAFLD and NASH can skip cirrhosis and go directly to HCC, thus resembling what many experimental models of HCC show. I mean, I've always been bothered by experimental models of HCC in which the animal doesn't go through cirrhosis. They just develop cancer because you expose them to something. And I always said, it just doesn't recapitulate real life. Well, now it does. So what's the risk of HCC in this very common condition characterized by just fat in the liver? This is one of the more important studies that we produced over the past few years, which basically is the largest and the only, I would say, almost population-based study that shows the risk of HCC in NAFLD. So through the national VA hospitals and clinics, we've identified a cohort of 452,000 and a change with NAFLD, and an equivalent number without NAFLD, like true controls. And we followed them over almost 10-year mean follow-up in the electronic medical records to look for HCC cases. 727 cases developed in the NAFLD group, 87 in the non-NAFLD group. The hazard ratio is 7.5. So clearly NAFLD, even the benign form, has an increased risk of HCC. It is much low in terms of the actual incidence. You can see 727 in 500,000, but relatively speaking, it is high. Well, who are those people? What can we predict about them? Yes, a lot of them, 80%, had cirrhosis, but 20% to 30% didn't. Tend to have diabetes, older, and Latinos are the other risk factors. The third and important, and now a lot of people talking about it, if you pile on the metabolic risk factors. So if you have a dyslipidemia, hypertension, diabetes, and obesity, you really rack up the risk, and you get up to 10-fold increase in the distant right bar. We've also found what my first cartoon has showed, which is 34.6% of NAFLD-related HCC happened in the absence of cirrhosis, as compared to much lower proportions in HCV, HBV, and alcohol. To make things worse, because NAFLD has this purest definition, it's non-alcoholic. And anyone who's seen patients or conducted studies in people can tell you how difficult it is to get history of drinking in people and to quantify it and to define them as drinkers or non-drinkers. And biology is not mutually exclusive. So someone could have fatty liver and alcohol, but the definition of NAFLD that I've shown in the previous 6 slides has this exclusion. If they have alcohol drinking, they cannot be considered. And that's not natural or normal. So now, if NAFLD is confusing enough, the new term is MAFLD. It's metabolic associated fatty liver disease, which basically says the definition is liver fat. Irrespective of what's the underlying thing, it could be cured hep C, it could be treated hep B, it could be a distant drinker. These are not exclusions. If you combine steatosis with overweight or obesity, or type 2, you qualify to be MAFLD. Even if you have a normal weight and you have metabolic dysfunctions, you could be MAFLD. And the estimate now is 1 billion people around the world may have MAFLD. Well, scared you enough? Let me end it on a more humorous note, not ending completely, but almost there. Coffee, please go refill. So coffee, epidemiologically speaking, is associated with lower liver enzyme activities, lower risk of cirrhosis and HCC. Several case control studies, which are dubious, but cohort studies, which are difficult to argue with, show consistently a reduction of 23 to 25% in the risk of HCC for each additional cup of coffee. So don't go running and drink 10, because clearly this doesn't work like this. You will not die of any cause if you drink 10 cups of coffee. There is a ceiling or a bottom that we don't know, but we think it's around 3 to 4 cups. It's coffee, meaning caffeinated, not much evidence for decaffeinated. It's coffee, not tea, although there's some talk about green tea. What's the reason? No one knows. Antioxidants, possibly. Caffeine is a strong candidate. Phytochemicals are possible. The problem is batches of coffee vary tremendously in whatever they have in them. But the one I like the most, that coffee has been shown to reduce insulin resistance and diabetes. So if you believe the plot about NAFLD and MAFLD, coffee fits right in. So this is a slide that epidemiologists love to show you the meaning of what I said for the population. So the first column here is prevalence in the general population. Hepatitis B and hepatitis C, the first rows, are really not common, 0.5%, 1 to 2%. But if you move over one column, they're highly virulent risk factors. If you have them and you're not treated, your risk of HCC is 20 to 25-fold. Those are astronomical numbers. by EPI standards. So if you take a rough multiplication of the two, you end up with a population attributable fraction of 20 to 25% in the case of hepatitis C and B. But the prevalence is dropping. The risk estimate is dropped once you treat them and cure them or you suppress them. So the population attributable fraction is rapidly dropping. But look at metabolic syndrome or MAFLD. Well, the prevalence could be as low as 30% and as high as 80%. They're really weak risk factors. 1.5 is probably generous. But you can rack up a lot of population attributable fraction by having a weak risk factor that affects a lot of people. It's a much more of a public health issue. So things have shifted, and I made up this graph I'm proud of, from risk factors that are very, very uncommon, but give you a lot of risk, that's previous state, to risk factors that are very, very, very common, but give you a low risk, which is highly confusing for the clinician and the provider, because you have people in front of you, they're not completely normal, and they're not high enough for you to act on it. So this is really my last thing. CPRIT, Cancer Prevention Research Institute of Texas, given the Texas issue, has funded us 5-6 years ago for a $12 million grant called the Texas Hepatocellular Carcinoma Consortium. It has 5 projects. You can tell by the title that I practice what I preach. Number 1 is called Risk Factors for HCC and NAFLD. Number 2, Metabolic Syndrome and Risk Prediction in HCC. Number 3 is slight variation on the theme, circadian disruption as a risk factor for HCC. Number 4, novel biomarkers. Number 5, comparative effectiveness for screening. We have embarked on building a cohort in 7 sites in 3 cities. We're now actually closer to 2,500 patients enrolled with cirrhosis, which is the precursor lesion for HCC. We follow them up every 6 months with ultrasound to see what happens with HCC. And the etiology of cirrhosis is exactly what I just told you. 75% has MAFLD, a small fraction has active hep C or active B. So this is the, ladies and gentlemen, this is the contemporary face of cirrhosis and HCC. So this is my last slide, the changing HCC risk factors. There is less active hep C and hep B, more metabolic syndrome. There's a lower individual risk, but more individuals at risk. HCC and metabolic syndrome, relative risk is modestly elevated. The absolute is low. Factors influencing that, abdominal obesity, diabetes, and NAFLD, and a lot of knowledge is needed in risk stratification and treatment. A lot of people have contributed to this over the years. Partial list is shown here. Thank you. This is the dreaded moment where someone would say you are on mute for the past 50 minutes. I guess I was.
Thank you. Thank you, Dr. El-Serag, for that excellent presentation and for taking us through really the history of HCC in this country and the changing epidemiology. I want to remind everybody in the audience, if you have a question, please add the question to the Q&A box on Zoom, and I will then announce it to Dr. El-Serag. I'm going to start with a question from Melissa Bondi. Melissa says, thank you for such an excellent presentation and for taking us through the epidemiology of liver cancer. For most cancers, epidemiologists have included SNPs or genetics. How do the genetics play a role with HCC? And for predictions, are there genes that increase risk beyond the known risk factors?
Yes, excellent question. And I just ran out of slides. Two general points. Several GWASs have been done. There has been a major hit on a gene called PNPLA3. The distribution of the genotype that is the worst is higher among Latinos. It is associated with NAFLD, associated with NASH, and possibly HCC. There are 3 other genes as a result of GWAS and some attempts, including from us, to form a polygenic risk score that contributes to the risk stratification. So that's the first point, that on a population level, you can find those things. What is completely unknown and possibly not going to work as well, if you look at the lesion that people look at, which is cirrhosis, will germline predisposition play a role when you have a liver that is already damaged and you have alcohol and hep C, et cetera, that remains to be seen. So typically, as you know, Melissa, it would be nice if the line of pathogenesis is direct from the gene to the lesion, as opposed to passing through 2 or 3 intermediate lesions. The answer, we don't know for that.
Okay, thank you so much. We have another question from Ray Kim. Hashem, great talk. What is your current thinking on HCC surveillance in non-cirrhotic NAFLD patients?
Thank you, Ray, and it's good to hear from you. The general comment is it is not recommended because the incidence is simply too low to achieve even the most optimistic cost effectiveness measures. There's an if to it. So the non-cirrhotics vary from non-cirrhotic with no liver damage, no fibrosis, to non-cirrhotic where the fibrosis is almost there, the so-called F3, fibrosis 3. There I could have a soft spot knowing how inconsistent or less reproducible non-invasive measures. So if I have non-invasive measures, 2 of them that show F3 borderline F4, I might bump that to the screening category, admittedly, not completely evidence-based at this point.
Great. I actually have a couple of questions for you, Dr. El-Serag. You know, this has to do with the NAFLD NASH spectrum. A couple of questions. One is the degree of fibrosis related to HCC risk? That's the first part of the question. The second is, you know, there are a bunch of NASH drugs that are in trials, things like obeticholic acid and FGF agonists. Do you think that those will have a long-term impact on HCC risk from fatty liver disease?
So the first one, the answer is very yes. And the degree of fibrosis measured by any means. There are biopsy-related studies. There are non-invasive like FibroScan and MRE studies that show a nice step-up correlation between the degree of fibrosis and the risk of almost anything bad. Overall mortality, cardiovascular mortality, and certainly liver cirrhosis and HCC. Having said that, there is that proportion that develops without this relationship being obeyed and respected, which means lower grades of fibrosis bypassing the higher grades of fibrosis before going to HCC. And this proportion is greater than what is known from other risk factors. Still, it's the most available clinical and best predictive way of the risk is fibrosis. Your second question is, no, I mean, the company may hate me for that, but no, I don't see it playing a major role. I mean, first, it's still not approved. When it's approved, it's going to be approved and used in a small number of people. The trick in this entity is one of 2 things. Either having something cheap and ubiquitous, metformin kind of thing, where you use it and you don't care. If you're using it on 90 people who are not going to develop cancer, you're not going to feel bad about it because you're treating your metabolic syndrome. Or very specific, if we have great stratification tools, and we don't have great stratification tools. So if we have this thing where we corner you and we say, because you are at the highest risk of HCC, why don't we give you this medication and maybe it will reduce your risk of cancer. So it's possible to do it in cirrhotics. I just don't see this from a public health standpoint making a major dent yet.
Okay, thank you.
We have to go there. I'm not saying we shouldn't develop the medications because something needs to be developed. But based on where we are right now, this is not a clear and present solution.
Thank you, Dr. El-Serag. I and others have more questions, but we're at the top of the hour. So let's go ahead and thank Dr. El-Serag for a fascinating and thoughtful seminar about a timely topic of HCC and metabolic disease.
And thank you. And I want to wish all of you happy holidays and hopefully next year that is better than this year.
Thank you so much. To finish, I just want to again thank all of you for your support of this Frontiers in Oncology seminar series. This was our last seminar for this year. We're going to start again next year. There will not be a FIO seminar on January 5th, but we will restart on January 19th when we will have a great seminar from Elizabeth Yaffe, an expert in pancreatic cancer and immunotherapy from Johns Hopkins. So with that, thank you for attending and have a good holiday.